So the bones and teeth support the shape and volume of the lips. So in young patients, you have to just see the support, but in elderly or senior age groups, the support is also lost, the dentition, the structure is also lost. So what do you do then? So first you have to see that the adding more volume to the lips is not going to compensate for the bony support or tooth support in the senior age.
Yeah.
But in the elder, I mean, in the younger patients, uh, always assess the tooth, because if teeth are jutting out, then the lips will look over projected as it is. And then if you're giving filler over top of it, it's going to look very odd.
Yeah.
Assess in the smile first and how the lips are changing while the person smiles.
Yeah.
And in some individuals, they will need orthodontic treatment before getting lip filler done. Ideally it should be like that, but most often it's not very practical, because if someone is coming for lip filler, you can't go and tell them, okay, you take 1 year off and first take orthodontic treatment and then come for lip filler.
Yeah.
Ideally it should be like that, but usually it is not. So you have to see that you don't add volume. If the lips are over projected, don't add more volume to the lips, so that they should not appear more over projected.
Yeah, that's right. Yeah.
So the dynamic lip area is controlled by muscles also. So these are the various muscles, smile muscles, and of their upper lip elevators and their lower lip depressors. And most of the confluence point is the modulus, where most of the smile muscles come and join along with the orbicularis oris.
Yeah.
The various muscles. And the most superficial is the orbicularis oris. All the muscles lie beneath it.
Yeah.
This is the SMAS again. Not very important in the lip area. Now, effects of aging, we have the changes in dentition can affect the how the lips, appearance of the lips. Then there is atrophy of bone, muscles, and subcutaneous tissue, and movement of the fat compartments. All these can contribute to how the lips appear during your senior years. And the effects of muscle movement on damaged skin. Now, this is important because the lips exhibit varied signs of aging. So what are the signs which are related to loss of volume? So first of all, there will be projection is lost. Then there will be drooping of the lips, of the corner and of the commissures also, and of the lip itself. And then there will be lengthening of the vermilion border. And there is the loss of definition of the filtral columns. So filtral columns will appear flat. The cupid's bow, the angle will become more obtuse. It will become more straight, the cupid's bow. So these are all related to the changes in the volume, loss of volume.
Okay, so the lengthening of vermilion border, does it mean widening of the lip, or does it mean the distance between the nose and the lip increases?
This is the nose and the lip increases.
Lengthening of vermilion border.
Because the lip
That
is
means
becoming flat. So this area.
So the distance between nose and lip is increasing.
Yes.
Okay, and loss of definition in the filtering columns, that's okay. Change in the orientation of the vertical and receded. Yeah, vertical and receded. Yeah, fine.
So loss of structure changes the orientation of the aperture and the lips become more vertical and receded. The muscle action and environmental changes will lead to the wrinkling of the skin. So there is depleted volume. There are fine lines and wrinkles on the lips and around the lips. There is loss of definition of the border. There is the flattening of the filtral columns. There is loss of cupid's bow, and there is downturning of the commissures.
Yeah.
This is how it happens. The youthful lips are everted like this, and the aging lips, they become so flat and they become inverted.
Yeah.
The lengthening of the this thing. Upper lip. Downturn of the commissures. Now, this downturning of the commissure, it unifies with the marinate line also. So they'll combine with the marinate line.
This downturning of commissure, is it linked with hyperactivity of muscles?
Yes,
or
not
is it because of
hyperactivity. First of all, there is loss of support, loss of volume,
Okay.
and there is loss of support, and then activity of the muscle. All these three contribute to the downturn.
So whenever you're working at commissures, do you give Botox also to
Uh,
depress her
Possible.
angle iris?
If person is taking Botox and fillers both, then I would, save 1 or 2 units for this area for DAO. But if they're not taking Botox, then I wouldn't do it because, it's not very practical because Botox, everything is calculated. For 2 units, I will not open a vial.
Yes.
And if I have something which is open, the vial is there, then that person is lucky, I can give 2 units over here to give good results.
Yeah. Got it. Yeah.
But if they take filler and Botox both, then I definitely save it for this.
Yes.
Even
Yeah.
if they're not getting lip filler done, if they're just getting a cheek filler only, but I will just add 2 units here and there.
Okay. Yeah. Yeah.
So volume loss can lead to flattening of the cupid's bow. Loss of volume in the upper lips is when the upper lip volume is lost, then there is the flattening of the vermilion border and the cupid's bow. And flattening of cupid's bow and the philtrum becomes longer and ill-defined, indirectly contributing to the thinner upper lip. So this also becomes elongated.
Yeah.
Increased wrinkling of the lips and surrounding area, ordinary actions of the orbicularis oris accentuates these. So since this muscle is very active, talking, speaking, eating, everywhere we are using orbicularis oris.
Yeah.
Because the muscle is very active, that's why wrinkling is even more. It adds to the wrinkling of this area. So lip through the decades, this is how they change, In 20s, they're like this. In 30s, they become slightly bow shaped. Then in 40s, puckering happens. And in 50s, it's like this, flat and puckered.
Yeah.
Now, when we assess the lips, 2 kinds of assessment has to be made. One is the static assessment and one is the dynamic assessment, right? The static assessment is at rest. We observe the proportion, volume, symmetry, and the position between the top and the bottom lips. And we also check the skin quality, texture line, filter column, white roll, oral commissure. All these points need to be observed first. Now, dynamic assessment is when the person is smiling. So how the smile is, how the vermilion changes with the smile, what is the relation between lip and nose when the person smiles, and the symmetry. Some people have this habit, which we call as the, dynamic muscle movement. They on purpose smile in a way that the smile becomes asymmetrical like this.
Yeah.
Right. So they do is on purpose. They are not aware because they're so used to it. So check for any asymmetries while smiling.
Yeah.
At rest, there might not be any asymmetry, but during the smile, that asymmetry might crop up.
Yeah.
So different types of smiles are there. One is the Mona Lisa smile, in which the highest points are the commission and the most common smile. This is the highest point, the commissures.
Yeah.
Then this is supposed to be the most common smile. This is the Mona Lisa smile.
Yeah.
Now, in canine smile, the highest point is the central upper lip. This.
Yeah.
The major dominant muscle in this type of smile is levator labiae superioris. In Mona Lisa smile, the dominant muscle is zygomaticus major, because this
Yeah.
is. And then full denture or Hollywood smile. This is where the upper lip and lower lip, I mean, the dentition is seen. Upper dentition and lower dentition both are seen. Usually in a normal smile, only the upper dentition is seen. And this, very few people have this. Like in this, the upper lip elevators and lower lip depressors both are active, which is the Hollywood smile.
Yeah.
So the 8-point lip reshape. Again, we check in this that the codes injection area. We have LP1, LP2, and LP3, first of all. So LP1 is the vermilion body. LP2 is the cupid's bow, and LP3 is the lip border. LP1, LP2, and LP3 border of lip.
This can you just again say? LP1 is the vermilion body.
Body. LP1 is these areas.
These two. Okay. Which we call, okay, these are bodies.
1, 2,
And
3. This is the body. This is LP2.
These are the tubercles. The lower lip, these are the tubercles,
Yeah,
but this body and tubercles are the same.
same. Yeah.
Okay, LP1 is this. Okay, and LP2 is this Cupid's.
Cupids, and LP3 is the border.
Got it. Fine.
Then LP1, LP2, LP3, LP4 is the medial tubercle and LP5 is the lateral tubercles. This is the LP4 and LP5. The numbering in this picture might be, confusing. Don't go by this. This is the LP4, medial tubercle. This is most often we are not injecting, we are not touching this area. And LP5 is the lateral tubercles, these. So usually LP5 and this LP2 point, they are almost the same. Is it confusing?
Yeah, a little, because the tubercle and
Yeah, don't worry. When we do this thing, it'll become clear, because these are all the points are not. Then LP6 is the oral commissure, LP7 is the filtered column, and LP8 is the perioral area.
LP6 oral commissure. LP7 is the filter column.
So for injection purposes, what is more important for us? All the 8 points we are not injecting anyway. So the most important point for us is the body, these 4 points. Forget about the tubercles, this inner triangle, forget about this. Fine?
Yeah.
So 1, 2, 3, 4. These 4 points are important. The border is
Yeah.
important. The oral commissure is important. So if anybody is coming to you for lip filler, these are the 3 points that you do.
Yeah.
And after that, if you feel the need, then you can look into the filtral column and the Cupid's bow. Cupid's bow we usually do not do.
Okay, why we are not doing Cupid's bow?
Because when you fill the vermilion body, the Cupid's bow improves on itself.
Okay. Yeah. Okay.
Once you do the body, this area becomes, already shows in the improvement on its own.
Yeah.
So LP1, when we do LP1 is this basically the body. We use either Ultra Plus XC or Volift, 0.05 to 0.1 with a needle. I don't prefer cannula in lips, because if you use a cannula, you are bound to go deep.
Okay, and you're giving bonus here? A bolus here?
Bolus or linear threading. Usually linear
Okay.
threading works. So you
Linear
give 2
threading.
threads like this, 1 and then 2.
Oh,
Right?
2
So
threads. What do you know through 2 threads?
two linear threads, like you divide this area into 2 parts. First,
Yeah.
you will insert the needle from here and then start injecting and come back retrograde like this. Then make a second entry point over here and then go till here and then come back.
And this injection is junction of wet and dry lip. Is it right?
Yes, you evert the lip, put the needle at the wet dry border, and then start injecting and withdrawing at the same time.
Okay, so this LP1 we have what? We get 2 linear threads.
Yeah.
And how far we are from the midline, the body? How far is from the mid tubercle?
See the length of the needle, no? You measure the length of the needle from here to here.
Okay, so start about that distance away.
Yes. So start first medially and then laterally. Do not do here first and then start.
Yeah, no, my question is, like in the center, here is the tubercle that comes in the center. I think that's LP4. So the distance between LP4 and LP1, how much is the distance between LP4 and LP1?
That
What should be the
depends on
ideal?
the length of your needle. Just measure.
Needle. Okay. Needle. Okay. Needle.
So you measure wherever your needle is ending, make that your entry point.
Okay.
Measure it from the needle.
Fine.
So that's why I'm saying you will need 1 thread over here. So when this is the insertion point, suppose this is the insertion point, you can either do linear threading, which is the safest and the best, or you can do slight fanning also. Very little fanning. But that becomes that with fanning, there are more chances of hitting the artery.
So when you are doing this fanning or linear threading, you are moving from lateral to medial?
No,
Are
medial
you
to
moving from
lateral.
lateral?
It's
Pardon?
retrograde.
Medial,
Retrograde linear threading.
medial to lateral, like this you will be filling.
Yeah,
Or,
like
or is it like this you are filling, or is it like this you are filling?
you insert the needle from here, this point,
Yeah,
bring your
yeah.
needle till here,
Okay. Up to
start
the tubercle.
and keep withdrawing the needle at the same time.
Got it. Yeah, fine. Yeah, yeah, yeah.
Bolus is not usually required. Bolus is given when you do the lower lip.
Okay.
So in
Mhm.
lower lip, either you can do this technique or you
Yeah,
can just, pinch this area, pinch the tubercle area
yeah.
and do a bolus over there. So
Fine.
that works well. So what I usually do is I do linear threads in the upper lip and bolus
Yeah,
lower lip in the area of the tubercles. And then when I have given bolus medially, then laterally I can give one linear thread.
yeah.
Okay.
Okay.
So in upper lip, 2 linear threads each side, and in lower
Yeah.
lip, bolus and medially and linear thread laterally.
So when you are getting the linear threads from LP1, one is moving towards LP4 and one is moving towards commissure
Yes.
from the LP1.
Yes.
So that both the sides are filled.
Both the sides are filled.
Okay, yeah. And we always remain little away from the commission. We do not come up to the commission. I was told
Not
that
up to, no,
this
not up to the commissure.
much area, 2 millimeter area you should not have any filler inside it.
Yes, you should not. This
The
angle, this
commission,
corner should not have any filler.
yeah, about 2 millimeter from the commissure should not have any filler.
Yes.
Yeah. Okay.
Right. So is that clear? This is the first point you do in any lip, If you are like, this is a no-brainer kind of a point.
Yeah.
Then second, after you've done this, then you see how much filler is left, how much is the expectation, and how much is the border required. Once these 4 points are done, these are the most important points. These cannot be compromised. Yeah. Right. Then after this, you can do the border. White roll, So
Yeah.
here, when you do the white roll, again, start from here. Start laterally. This to this, and then this to this. So
So
lateral.
when we are filling the lateral row, the white roll, should we be away from the commissure? How far we should start away from the commissure, or we can start from the commissure itself?
No, not the commissure, just slightly medial to the commissure.
Medial to the commissure. Okay.
Slightly medial.
Fine.
1 to 0.2 millimeter medial to the commissure. Inject here first and then here.
Yeah, got it.
And this again has to be retrograde linear. Or whatever your comes. The injection technique is your own, I'm just telling you.
Yeah.
Okay.
Mm-hmm.
And then when you do the lower lip, so here you have to inject in the white roll horizontally, this area. Any side start. And here you can do again one and like this.
Okay.
Fill medial, insert the needle lateral to medial and start filling medial to lateral. So in upper lip, if you are doing the border, then there are 4 entry points. 1, 2, 3, 4. And when the lower lip we are doing the border, then there is 1 for the middle and lateral 2. So total 3.
Yeah.
Fine.
Yeah. Fine.
So product could be lift or Ultra Plus XC. If Ultra Plus XC, then we have to see that it hydrates a lot. So the swelling is going to be more if you're using Ultra Plus XC as compared to lift.
Yeah.
Right? Whenever you're injecting, ask the person to slightly open the mouth.
Yeah.
Then this is the vermilion border. Vermilion body.